Welcome to the Yale20. My name is Eric Jordan. I'm one of the internal medicine residents.
And I'm Jeff Connors, one of the pulmonary and critical care faculty and one of the associate program directors for the internal medicine residency. And today is the second part of our lecture on the management of shock.
As a reminder, in this second part of the shock series, we will be discussing the initial assessment of someone in shock, the different types of shock and their treatment, how to write up a good note for someone in shock, and finally, summarize the take-home points. I'll pass it off to Dr. Connors now, who will tell us a bit about what to consider in the first few minutes of encountering a patient in shock.
So when you're presented with a patient who may have shock, you first need to ask yourself, as we discussed in the previous video, does this patient truly have shock? What kind of shock is this? And finally, what needs to be done for treatment, which generally involves establishing some sort of vascular access. We went over in detail the definition of shock in the first part of our series, but remember that hypotension alone does not mean a patient is in shock, and conversely, a patient can be in shock without being overtly hypotensive. In order to make a diagnosis of shock, there needs to be a state of cellular and tissue hypoxia, which is manifested clinically as a rising lactate with evidence of end organ damage. Let's take a look at how to triage a patient who has low blood pressure and/or shock. In the case of a patient who is hypotensive, but their blood pressure is responding to fluid resuscitation, and there is no evidence of a building lactate or end organ damage, they can safely be watched on the general medical floor, but be sure to check up on them frequently as this state could change for the worse. If someone has evidence of shock with a rising lactate, but no evidence of end organ damage yet, a good place for them would be the step-down unit, since they might quickly turn the corner and go into full overt shock. Finally, if a patient has evidence of end organ damage from shock, which is seen by indicators such as a rising troponin, worsening lung function, decreased urine output or rising creatinine, or worsening liver function, then they certainly require admission to the intensive care unit.
Once you have established someone has shock, you next need to determine what type of shock it is in order to direct the treatment. For a brief overview, shock can be categorized in a number of different ways. First, as pump failure, meaning the heart is not able to pump effectively, which is how we are classifying cardiac shock and obstructive shock. This is diagnosed with help of ECGs, troponins, echoes, imaging studies, and invasive procedures such as placement of a Swan-Ganz catheter. Next is shock due to low volume, which is either hypovolemic shock or a more specific type called hemorrhagic shock. A good volume exam, which can often be difficult, is the key to diagnosing these patients. Additionally, a CBC could show someone is in hemorrhagic shock if their hemoglobin and hematocrit is much lower than their baseline. However, this might not be seen initially if the blood has not had time to equilibrate after acutely losing blood. And finally, there are types of shock involving blood vessel tone or distributive shock, such as septic shock or endocrine shock. Septic shock is defined by the SIRS criteria shown here, along with the documented or suspected source of infection. Sepsis is now also being defined with the SOFA criteria. However, the differences between these classifications is beyond the scope of this talk. Endocrine shock can be shown by a low cortisol level. Note that there are more specific causes of shock than are shown here, but these are the basics. In terms of treatment of shock, you often have to establish vascular access for fluid administration, as in the case of hypovolemic or septic shock. The question then arises, should we use a central line or peripheral IVs for the initial resuscitation effort? One may think a central line is the best option, however, the experienced clinician knows that it depends. Dr. Connors, can you bring us through the options?
Absolutely. So there are a number of different types of central lines shown here with different outside diameters referred to as French units, and the greater the French unit, the greater the diameter, and also with a number of different lumens. The triple lumen catheter for administration of multiple medications and fluids is most commonly seen in the medical ICU, but there are also single lumen introducers and other lines that can work for large volume administration and certainly work better than the triple lumen catheter if you need to get that volume in quickly. There are also a number of special double lumen catheters also used for hemodialysis, although these are slightly different in their indications and usefulness. But in the acute setting, when you need rapid fluid administration for the treatment of undifferentiated shock, which is the best choice? It might be surprising, but oftentimes the best choice is two large bore IVs, large meaning 16 or 18 gauge, with the smaller the gauge number being the larger the IV. This is due to the physics of fluid flow, as shown in the equation here, which states that flow is directly proportional to the fourth power of the radius of the conduit and inversely proportional to the length of the conduit. That's a very complicated way of saying that the shorter something is and the wider something is, the faster fluid will move through it. This equation takes into account things such as fluid viscosity and pressure drop, But to simplify things on the medical side, as we were saying, it's important that catheters be larger in diameter and shorter, and therefore the faster you can run fluids through them. This means that short, large-bore peripheral IVs, which are often easier and quicker to insert than central lines, should be your go-to for the initial resuscitation efforts. As an example, a 1.2-inch 16-gauge IV, which you'll commonly find on your medical floors and your ICUs, can accommodate about 220 milliliters per minute or 13.2 liters per hour of fluids, as opposed to a 7 French triple lumen central line, which can only accommodate flows of about 3.4 liters per hour, depending somewhat on the lumen gauge. After establishing your vascular access, it's important to give more specific treatments based on the etiology of the shock state itself. In the case of shock affecting the macrocirculation with a low ScVO2, such as cardiac or hypovolemic shock, you need to target the delivery of oxygen by giving blood if needed and optimizing the cardiac output. In the case of septic shock, which affects the microcirculation and often has a high ScVO2, early goal-directed therapy with IV fluids, antibiotics, and initial resuscitation efforts has been shown to reduce mortality. Next, we will go into the specifics of other therapies, including how much oxygen, volume, blood, or vasopressors to give when these are indicated.
First, if the patient is either intubated or receiving non-invasive oxygen, you will be able to dictate how much oxygen the patient receives. Note that there is no such thing as hypoxic shock, as the PaO2, here I'm describing the partial pressure of alveolar oxygen, does not reflect the oxygen content in the blood, but is rather a marker of lung function. Thinking about it logically, it doesn't make sense to give oxygen to someone who lacks the physiology to deliver that oxygen, so the focus should first be on optimizing hemodynamic status. Additionally, we know that due to the generation of free radicals and oxidative stress, too much oxygen can be toxic. Therefore, the two key points are 1. For patients on ventilators, they should be weaned down to less than 70% FiO2 or as low as they can manage without becoming hypoxemic when possible. And 2, 100% FiO2 will not help in shock. Now let's take a look at hemorrhagic shock and blood transfusions. As was stated before, a CBC is a good tool for diagnosing hemorrhagic shock. However, it can be misleading at times. For instance, in the acute phase of hemorrhage, there is an underestimation of blood loss, i.e., the hemoglobin will read higher than it actually is, given a lack of time for the red blood cells to equilibrate, since there is initially a loss of both red cell mass and plasma. Also, after IV fluid resuscitation has been given, there is a tendency to overestimate the amount of blood lost, since there will be some hemodilution from the IV fluids. Therefore, it is important to take into clinical parameters such as monitoring vital signs, looking for elevated lactate, and observing the previously mentioned signs of shock. The next question that arises is, what are our transfusion goals? A few trials described here help answer those questions. An often mentioned study, called the TRICK trial, randomized critically ill patients to either a restrictive transfusion goal with a hemoglobin of 7 or a liberal goal with a hemoglobin of 9. It found that patients actually did better with the restrictive strategy, and a more recent study, this time conducted with patients with active GI bleeds, also found better outcomes with the restrictive strategy. This leads us to our current practices, in which we transfuse people when their hemoglobin drops below 7. The one caveat is that we have a higher goal of a hemoglobin of 9 for patients with significant coronary artery disease.
So let's turn our attention now to the separate but related concept of hypovolemic shock. Since volume status is often difficult to determine, before giving fluids you need to ask yourself, will the patient benefit from fluids, or can fluids actually harm my patient? This can be determined by knowing if your patient is preload responsive. Taking a look at a ventricular function curve, which is governed by the Frank-Starling relationship, we can see that increasing the heart's preload will increase the heart's cardiac output, but only up to a certain point. On the left side of the curve, when patients are volume down, giving them more fluid can augment their cardiac output by resulting in greater stretch of the myocytes and increased strength of ventricular contraction, which is seen at point A. But if too much fluid is given, the heart's ability to pump actually starts to decrease, and congestive symptoms can be observed. This is seen here when you move from point A toward point C. So how does one determine this important point on the curve for your individual patient?
As is usually the case with medicine, a good differential begins with a good history. You can expect someone who is volume down to have a history of insensible losses from vomiting, diarrhea, or heat exposure, or they may have a history of blood loss from a GI bleed, trauma, or even present with back pain from a ruptured AAA. The next step is to move on to the physical exam, which can be difficult and overall is not great for determining volume status. Next, in the ICU, you are able to take both static and dynamic measurements. For example, you can measure the central venous pressure, which you would expect to be low, less than 8 millimeters of mercury, and the pulmonary capillary wedge pressure, which can be preserved or in more severe cases, reduced. Dynamic measures refer to giving fluid challenges and seeing how the patient responds, or using imaging to see movements of certain anatomical structures and how it is related to volume status. I will be going into each of these in more detail over the next few slides. As stated before, the physical exam, although helpful, is not perfect, and each individual exam finding, when taken alone, tends to have a poor predictive value for hypovolemia. Therefore, clinicians should rely on multiple findings that can change your pretest probability rather than one physical exam finding alone. With that being said, the study shown here did find that a large postural pulse change of greater than 30 beats per minute and severe postural dizziness correlated with large amounts of blood loss. If one suspects hypovolemia from another cause beyond blood loss, the authors of this paper suggest confirming it with laboratory data. For static measurements, such as the central venous pressure, I'll be briefly discussing the study shown here, which was conducted on mechanically intubated patients with sepsis. In the study, a pre-infusion CVP, or pulmonary artery occlusion pressure, was measured. 500 cc's of a colloid called hydroxyethyl starch was administered, and the patients were observed for an increase in cardiac index by 15% to be classified as responders, R, versus non-responders, NR. As you can see, the distribution of pre-infusion values between responders and non-responders was barely significant and had significant amounts of overlap. The cutoff of a CVP of less than 8 for fluid responsiveness had a positive predictive value of only 47%, or essentially the same as a coin toss. Another way to look at that data is that by using a cutoff of 8, you would miss some individuals that would have responded to the fluid challenge, and you could have hurt some other individuals with a low CVP who wouldn't have responded anyway. Long story short, cardiac filling pressures offer a poor prediction of fluid responsiveness. So if the physical exam and static measurements aren't great indicators of volume status, what about dynamic measurements? Again, we see a Frank-Starling curve, and as a reminder, patients will be fluid responsive when on the steep portion of the left side of the curve, but less responsive and potentially harmful as the curve flattens out to the right. One way to give a fluid challenge is to give a bolus of normal saline. However, if you are unsure of whether the patient is on the curve, this could be potentially harmful. Another way a fluid challenge can be achieved is simply by performing a passive leg raise, in which you raise the patient's legs as they are in the supine position, and this results in an intrinsic bolus of about 300 to 500 cc's. Most importantly, this is reversible once the legs are lowered. Another way to make a dynamic volume measurement in intubated patients include the variations in arterial pulse pressure as well as respiratory variation of the IVC diameter. A concept that needs to be understood first, though, is the difference between spontaneous breathing and mechanical ventilation. During normal respiration, which is referred to as negative pressure ventilation, there's a decrease in intrathoracic pressure during inspiration and an increase during expiration. The exact opposite is true in the case of mechanical ventilation, or a form of positive pressure ventilation, where during inspiration, there's an increase in intrathoracic pressure and a decrease during expiration. Because of these pressures, during normal breathing, when there is a drop in intrathoracic pressure, there is also decreased pressure on the right side of the heart, which allows for increased venous return and is visualized as a decrease in the diameter of the IVC. During mechanical ventilation, the positive pressure during inspiration is transmitted to the right side of the heart. If it is underfilled, and therefore more compliant, it will decrease the venous return gradient and the IVC will bulge as seen here. If the patient is normal or hypovolemic, there should not be any associated increase in the IVC diameter. In the case of spontaneously breathing patients, or those who are intubated but on a ventilation mode that allows them to initiate a breath, a drop of 1 millimeter of mercury or greater seen during inspiration also correlates with fluid responsiveness, with a positive predictive value of 84% and a negative predictive value of 93%. Here we can see in the top panel an inspiratory fall marked by the arrows, and each inspiration is marked by the black bar beneath the tracing. In the bottom panel, during inspiration, there is no associated inspiratory fall in the CVP. The variation that is seen in the lower panel is due to inherent variations in the CVP due to atrial and ventricular contractions. But what happens if we have a patient in shock with low blood pressure who is not volume responsive? This is when we turn to the use of vasopressors. A vasopressor is a drug that induces vasoconstriction and thereby increases the mean arterial pressure. They differ from inotropes, which are drugs that increase cardiac contractility. Many drugs will fall into both categories, but often they have predominant features of either increased TPR or increased cardiac output. The relevant physiologic receptors are alpha-1 and alpha-2, beta-1 and beta-2, and dopamine receptors. Their anatomic locations and respective effects are given in the table here. I'll now highlight a few commonly used pressors, the first of which is dobutamine, which primarily has beta-1 agonist effects to increase heart rate and contractility, as well as some beta-2 agonism, which results in vasodilation. Dopamine is an interesting pressor since its effects are dose-dependent. At low doses, it mostly affects dopamine receptors, causing increased blood flow in the renal and splanchnic circulations, as well as beta receptors, so it acts more like an inotrope. At higher doses, it will activate alpha receptors and act more like a vasopressor. Norepinephrine, the trade name of which is Levophed, mostly has affinity for alpha-1 receptors and is the preferred catecholamine to use in septic shock due to decreased adverse effects compared to other catecholamines. But otherwise, it doesn't have any mortality benefit. Phenylephrine is a pure alpha agonist and therefore can result in side effects of bradycardia, lower cardiac output, and renal hypoperfusion. Finally, vasopressin, or ADH, activates V1 receptors located in the vascular smooth muscle and is used in cases of septic shock that are refractory to norepinephrine or dopamine, or in cases of esophageal or gastric varices to promote splanchnic vasoconstriction. Now we will move on from hypovolemic shock to septic shock. The key to treating septic shock is early antibiotics and fluid resuscitation. In terms of antibiotics, it is important to determine where the source of infection is coming from, which may require further imaging or studies. Additionally, appropriate source control means draining any abscesses that antibiotics alone will not fully treat. As a reminder, patients in septic shock often have a high SCVO2, so if it is inappropriately normal or low, it could be a sign of recovery from shock or another overlapping cause of shock. If there is another cause of shock present, it should be treated accordingly, as we have discussed earlier in the video. A classic paper, which is a must-know for anyone in the ICU, is the early goal-directed therapy paper by Rivers. The algorithm used by Rivers to treat patients is shown on the left, with the main points of his treatment being early antibiotics, as well as administration of fluids, vasopressors, and blood transfusions guided by objective measurements of MAP, CVP, and SCVO2. The study resulted in a significant mortality improvement, but there were some criticisms of the study which were called into question with the process trial. The ARISE trial, which was a much larger randomized trial of 1,600 patients, however, it is important to keep in mind that it was unblinded, did not find any major difference in mortality, but it did find that the overall mortality rate was much improved compared to previous studies. Therefore, it called into question the early goal-directed algorithm proposed by Rivers. What the overall results of these studies show is that although the Rivers protocol was not perfect, the important points to take away from it are that early antibiotics and fluids are the key to treating sepsis successfully. Additionally, as we have learned more about sepsis and shock in general, some of the goals proposed by Rivers, such as static markers of volume status, are now outdated. We also use more conservative transfusion goals now and have an understanding that the delivery of O2 is not the major problem in sepsis, but rather the inability of the tissues to use oxygen. After talking about a couple of different types of shock, I'd now like to turn to the practical aspects of a write-up for a patient in shock. The major area where the note differs from the note that would be written on a general medical floor is in the assessment and plan. Rather than writing out the assessment by problem, it is written out by each organ system, as well as infections, which can fall into a number of different systems, but has a special section due to its importance. As an example, the first section here is cardiovascular, under which you can place the problems affecting the cardiovascular system. If the patient is in shock, you would give the etiology of the shock, its severity as evidenced by end organ damage, and information drawn from the H&P labs and imaging that support your differential. Other important areas to consider under cardiovascular include how the heart is pumping, if there is evidence of ischemia, and if there are any arrhythmias. The next section we have here is infectious disease, under which you should list any positive SIRS criteria and pending cultures, and what has been done for treatment in terms of antibiotics and source control. The rest of the assessment and plan continues in a similar fashion with the other organ systems. For our final slide, I'd like to remind you of the ways an SCVO2 can be helpful, whether low or high, to help diagnose the type of shock. Remember that for etiologies of shock involving the macrovascular circulation, the key treatment is to improve the delivery of shock, whereas with forms of shock affecting the microcirculation, such as septic shock, the key treatment is early antibiotics and fluids. You can increase cardiac output by first addressing volume status and then using vasopressors if needed. When assessing volume status, dynamic measurements are more reliable than static measurements. And when giving blood and oxygen, it is better to be more conservative with a blood transfusion threshold of a hemoglobin of 7 and limiting FiO2 to less than 70%. That's everything for now. I know this has been a lot of information, but with the tools we have given you here, you should have a good understanding of the basics of shock. Please make sure to come back to the video to reference anything you need to see again. Thank you very much for listening to this Yale20 video on shock.